Hello, everybody. This is Dr. Eric Scheier coming to you from Israel to discuss transabdominal point-of-care ultrasound for ovarian torsion in 10 minutes or less, possibly 15. So let's get started. Why is POCUS an important application in the evaluation of pediatric ovarian torsion? First off, pediatric ovarian torsion is not a rare entity in the pediatric emergency department. The incidence is 4.9 per 100,000 children, and up to 4% of pediatric emergency department visits for abdominal pain are diagnosed with ovarian torsion. Misdiagnosis can have sequelae. Ovarian necrosis, and I should mention at this point that even if ovarian necrosis is found grossly on surgical examination, most centers practice ovarian sparing surgery, so the ovary is distorsed and left to recover, and the majority of these patients do very well. However, ovarian necrosis is nonetheless a concern. The oophorectomy rate is and has been for some time about 2%. Ovarian necrosis, I should say misdiagnosis of ovarian torsion can result in peritonitis and shock. Using POCUS in the emergency room can decrease length of stay by about 2.5 hours compared to patients who are evaluated through radiology ultrasound. Now, the incidence of pediatric ovarian torsion is similar to that of pediatric testicular torsion. However, the rate of oophorectomy is approximately 1.5 times that of orchiectomy. Why is that? Abdominal pain in males, I was taught, in the evaluation of abdominal pain in males, a testicular examination is required. So for abdominal pain in females, why aren't we scanning them all for ovarian torsion? Delayed diagnosis is unfortunately common. Necrosis can begin after as little as 10 hours. 38% of premenarchal and 20% of postmenarchal children had a delay of between 12 hours to 4 days. 34% and 17% of the overall had necrosis on surgical exam. The pain does not necessarily need to be, the classic is the sudden, severe abdominal pain, and that is not necessarily true in the pediatric population. 41% of patients with torsion presented to the pediatric emergency department after 2 days of abdominal pain. 33% presented with a VAS, is the visual analog score scale. It's a pain scale with 10 being the most severe pain. So 33% presented with a VAS of 6 or lower, and 3 patients had been discharged from the PED, Pediatric Emergency Department, the day prior to diagnosis. And a second series reported that a large number of these patients present with non-severe pain more than 2 days, and that in a large number of patients on examination, there are several twists to the adnexa, which may suggest chronicity. And in this last series, 44% had multiple discrete episodes of abdominal pain over a period of between 24 hours and 4 weeks in which they were suffering from abdominal pain. So how is the examination done? I would like to take a moment to thank my daughter Miriam for this sketch. She is graduating from Hebrew University with a degree of international studies, if anybody is looking to hire. She's also a wonderful illustrator. So we take the curvilinear probe. Now remember, the curvilinear probe allows us to see objects that are deeper to the probe, specifically intra-abdominal organs. And of course, the indicator is always to the right of the patient or to the patient's head. So here we have a transverse orientation, and you put it right above the pubic symphysis and fan downwards, fan caudally towards into the pelvis. And that is in the transverse orientation, and then we just turn the probe 90 degrees so that the probe marker is oriented towards the patient's head, and we scan in sagittal orientation. What does normal look like? So here are chocolate chip cookies. You have on the left an image of 2 normal ovaries. You can see that the stroma has an echogenicity that is similar to most intra-abdominal organs, indicating that is not currently edematous. It really does look like chocolate chip cookies. You've got these little follicles in here. They're sitting off laterally to the bladder. This is the hypoechoic bladder right in the center here. That's really the first thing that you see when you are fanning in towards the pelvis. Here you can see that even without a full bladder, I can still start to make out my chocolate chip cookie. And at this point, I can tell you that this is a healthy ovary. This is not a torsed ovary, I can say that. I don't see the pole of it here. So, and sometimes you can see both in one view. Here I'm rocking back and forth. So with a bladder this size, so we use the bladder as an acoustic window. So I'm now oriented transverse, and I rock the probe. Towards the patient's right in order to use the bladder as an acoustic window to view this left ovary, and I do the opposite in order to view the right ovary, and then sometimes you can see both in one shot here. And here I am rocking the ovary again. On sagittal, the ovary can have a variety of positions. Here we have a normal ovary, and here we have normal ovary. You can see that they are in different positions behind the bladder. And they can even be superficially located. And so if you don't find it on first try, scan around. Of course, when we are scanning in sagittal, you'll see this in transverse as well, but it's much easier to pick up on sagittal. The uterus, here's the uterine fundus and the endometrial stripe right down the middle. The cervix is here, and then the vaginal canal runs in this direction. And this is just another view of a normal healthy ovary on sagittal. Again, it can be seen without a super full bladder. This is actually a 6.5-year-old patient who came in this morning. So this picture is fresh off of the machine. And here you can see on sagittal, let's run through this once and then I will describe. And so in sagittal, we can start with the right ovary, okay, and then you're fanning through, and in midline, we just picked up the uterus, and here is the left ovary. And so we start in sagittal by rocking the probe, using again the bladder as an acoustic window, and rocking the probe so that the right ovary is in view. And then you basically, I'm sorry, rocking is the wrong term. We're going to be fanning because the probe is in sagittal. So we're fanning so that the right ovary comes in view, and then just fan right through. You can see right here is was the uterus. And as we continue fanning, here's the right ovary, uterus here. And as we continue fanning, the left ovary comes into view. So what are the sonographic signs of ovarian torsion? Now that we've seen normal, what is abnormal? Well, the books say 4 centimeters, and that is the accepted wisdom in adolescents and adults. 4 centimeter maximum diameter, or in younger children, a 50% increase in volume compared with the unaffected ovary. Now, volume is a little bit of a difficult measurement to obtain, particularly for relative novices, which includes myself. I use diameter. But a recent series of pediatric patients, this was actually just published several months ago, showed a 5.5 time difference in volume between affected and unaffected ovaries. So the difference here is marked. This is not a subtle difference in size that we're looking for. The ovary, as it torses on its stalk, will find itself in a location along the midline of the body. We'll see the picture of that in just a moment, with peripherally located follicles as the edema pushes them out towards the periphery, increased echogenicity with what's called the follicular ring sign. We'll see a picture of that in just a second. The double bladder sign, I've got a picture of that. Free pelvic fluid is relatively nonspecific. And then you've got the whirlpool sign, which is really the ovarian vessels. It's the torsion of the ovarian vessels, similar to a pseudomass that you'll see in testicular torsion. And the whirlpool sign is actually quite difficult to pick up, and therefore I do not have a picture of one. This is a torsed ovary. You can see it's over 4 centimeters in diameter. You can see that it is more echogenic than the other ovaries that we've seen. The stroma is more echogenic. Here we've got peripheralized follicles, and here is follicular edema. So you've got a transition between stroma and follicle, and that increase in edema around the rim here is what creates the follicular ring sign. And again, just to show you the difference between affected and unaffected ovaries, this is the same child. This is an affected ovary. This is a torsed ovary. And here we can begin to see the unaffected ovary. And if I just change the orientation of my probe just a touch, so the affected ovary is now out of view, and the unaffected ovary, you can see, comes in view, and you can see how different this ovary is than this ovary. And just remember, in most shops, we have gynecology to be our definitive answer to abnormalities that we find on POCUS. And I recommend that that everyone starting out, if you find an abnormality, refer it on to gyne. Here we have, again, just another photo of a large, this is kind of the oversized chocolate chip cookie. This is a large torsed ovary with peripheralized follicles. One thing I did want to mention on this photo here is this is a pure transverse view of the bladder, and you can see how medialized this ovary is. It's sitting right under the bladder. So this is a transverse photo, transverse image. And so the torsion brings the ovary in to the midline. You can see it sitting along the midline, just under the bladder. And this is the double double bladder sign. I'm sorry, the double bladder sign, in where we have a large cyst-like structure, hypoechoic fluid inside, with another large cyst-like structure, hypoechoic fluid inside. One of them is the bladder, and one of them is just a large cyst around which this ovary has torsed. You can see under it, this is our torsed ovary. And we wonder which is which. So you might say, okay, well, maybe this is a ureteral jet. Okay, so maybe that's the bladder. Well, in order to tell which is which, and again, I just to orient you, this is a sagittal view using a curvilinear probe. Which is the bladder and which is the cyst? Well, we can use our uterine fundus. You can see here, your uterus is, and this is not the clearest photo, I will admit, but it is sitting under the bladder, and that is the proper orientation. The cyst is kind of off. The cyst was actually off to the left side. And so that's the double bladder sign, point being, if you do see this, referred on to gynecology, particularly if you've not found the torsion, it may be there. So is Doppler flow required? The ovary has dual blood flow. Presence of flow does not rule out torsion. A torsed ovary can present with normal arterial flow in almost 1/3 of cases. And one series, only 38% of torsed ovaries were found to have lack of Doppler flow, meaning that 62% of torsed ovaries had flow on Doppler. And so my own practice is not to use Doppler so much. If it meets the other criteria, then in my book, it's torsed. The one exception that I do make is if you have an ovarian hernia. So this is an infant here's the stalk of the ovary coming through the hernia sac, and you can kind of see this is a bit of a chocolate chip cookie. We've got follicles in there, and you can see, I like to show that there's good flow in there, and in addition to there being no edema, and touching base with the surgeon before I discharge them home. Okay, what are the torsion mimics? So you can have enlarged ovaries without there being torsed. A neoplasm can have, I see I'm running over time, so we're going to do this very quickly. A neoplasm can be the source of a torsion, the locus of a torsion. A hemorrhagic or simple ovarian cyst can cause lower abdominal pain, and can be, again, the locus around which an ovary torses. An involuting corpus luteum, I have a good photo, a good picture of that. And then an isolated torsion of fallopian tube, I do not have an image of, but basically what you'll see is that the tube is this edematous mass alongside a normal ovary. And so here, enlarged ovaries, you can see this is a 9-year-old girl who has just this enlarged ovary, but you can see that the stroma is not echogenic, a large follicle, if not cyst, sitting here in the ovary. And this child went through extensive evaluation and was not forced and was not found to have any other pathology, and was discharged and lost to follow-up, and I hope she's well. This is an ovarian cyst, a 5-centimeter cyst. Generally with cysts, you can see some free fluid is leaking out. You can see generally with cysts, below 2 centimeters, nobody really gets excited. After over 2 centimeters, I'll send them to start having gyne follow, and they really don't get excited until it's 4 centimeters. But it can be the cause of the torsion. So again, if you have a large cyst and you have a child, large cysts that are causing pain may, in and of themselves, need to be treated. They may need to be aspirated. But we want to, if you have a large cyst and a lower abdominal pain, we do like to see the ovary well and show that it is not forced. Here you have, of course, the previous photo that we just saw. This is a simple cyst, large simple cyst. You have an ovarian cyst here with septations. This is a complex cyst. So all of these, regardless of size, need to be evaluated. Involuting corpus luteum is another interesting entity. This is a child who came in just several weeks ago. We've got stroma that's not very edematous. It didn't meet size requirements. You can see that there is flow. These are my images. Once in a while I break my rule, and I do put Doppler on, and these are, you can see some flow here. We sent her to gynecology, and you can see this is a comparison between my image here and gynecology image. And the one thing that is diagnostic of very, I don't know about diagnostic, but very suggestive of involuting corpus luteum is this hypocoic cleft here. And you can see that they showed good flow, and this child went home well. Thank you very much for your attention. See you next time.